Hello, everyone. I'm Wajiha Ali, and I lead the heme pillar at Axiom Healthcare Strategies. We are a boutique think tank style consultancy working across the areas of solid tumors, heme malignancies, and rare diseases. I welcome you to the second event in our mid-year town hall series. Today, we will be discussing the updates from the field of lymphoma that emerged from the three conferences that took place recently, ASCO, EHA, and ICML. Next slide, please. I'm joined today by our esteemed panel, Drs. Maziar Shadman from Fred Hutch, Dr. Matthew Matassar from Sloan Kettering, Dr. Alessandra Ferraholi from MD Anderson. And this panel will be spending the next hour discussing some of the updates from CLL, FL, DLBCL, NCL, and HL. Next slide, please. Right. So our agenda today will be that we will start off with some of the updates from the BTK inhibitor space in CLL, followed by practice impacting data from NHL and CLL, and then cell therapy in lymphoma, latest data on CD20 bispecifics, and spotlight on some of the novel investigational drugs in lymphoma, and finally, updates from Hodgkin's lymphoma. So with that, I hand it over to the panel. Over to you. Thank you so much. Next slide, Mara.
So thank you for the invitation to discuss this town hall, the data that have emerged from ASCO, EHA, and the Lugano meeting. And I will be focusing mainly in chronic lymphocytic leukemia, small lymphocytic lymphoma that are my field of interest. The first study that we are presenting is the Alpine trial. This is a phase 3 randomized trial for patients with relapse and refractory CLL and SLL that have been randomized to receive treatment with the standard of care, that is ibrutinib at 420 milligram daily, or zanubrutinib at 160 milligram twice a day. Zanubrutinib is a next generation BTK inhibitor that has a more narrow profile of targeting kinases than ibrutinib, with less effect on TEC and VEGF, and therefore considered to be more specific for targeting BTK. This is the first ad interim analysis, is a plan analysis, and is conducted 12 months after the last of the first 415 patient initiate therapy. The primary objective is overall response rate, and the overall response rate in this trial was considered as complete response plus partial response. And it showed a superiority for zanubrutinib with 78% overall response rate compared to a 62% overall response rate with ibrutinib. However, partial response with lymphocytosis was not considered. And this is when we incorporate partial response with lymphocytosis, we see a difference of 88 overall response rate for zanubrutinib versus 81 for patients treated with ibrutinib. Progression-free survival is shown here, and at this 12 months landmark analysis, it was 95% for zanubrutinib versus 84% with ibrutinib. And this was statistically significant. As we would expect, this is an early view of the data. Therefore, there is no significant difference in terms of overall survival. That is, again, 97% for zanubrutinib versus 92% for ibrutinib. Looking at the safety analysis, there is always a focus on safety analysis when next generation BTKI are compared with ibrutinib. In this case, looking at the safety analysis table, I would like to point that adverse events leading to treatment discontinuation were more common with ibrutinib, 13% versus zanubrutinib, 7.8%. This was an early study, but atrial fibrillation was also looked at, and the rate of atrial fibrillation with zanubrutinib was 2.5%, and for ibrutinib it was 10%. There was no difference in terms of the other cardiovascular effect that is always evaluated, that is hypertension, and that was 16% between the two studies. So basically, this first look at the data, this first plan ad interim analysis shows that next generation BTKI are effective, and they have a profile in terms of toxicity that seem to be more favorable in terms of less side effects that are related to their own off-target activity. There was, looking at side effects, a higher rate of grade 3 neutropenia with the patient treated with zanubrutinib. And that rate was 18% compared with 15% with the patient treated with ibrutinib. However, there was no difference in terms of grade 3 infectious complications. So again, this is the message that we have from the Alpine trial, the first ad interim analysis. The next slide. So the second study was presented at EHA by Dr. Kater, and this brings up a very important point for CLL investigator, and that is the activity of fixed duration therapy. This is a study that compares fixed duration ibrutinib plus venetoclax compared to the standard of care in many countries, particularly in Europe, that is the combination of chlorambucil and obinutuzumab for patients with CLL and SLL that had not received prior therapy. The patients that were enrolled in this trial, is important to notice, were patients either old, 65 years of age or older, or patients that had were younger than 65, but they had severe significant comorbidities. So this is a trial done in a population that mirrored the population that we see in the clinic. In fact, the median age was 71 and 72. So as we expected, the overall response rate was similar between the two trials, but the complete response rate was higher for the patient treated with the combination of ibrutinib with venetoclax. It was 45% versus 13% with the patient treated with chlorambucil and obinutuzumab. But what is important is looking at the progression-free survival. The follow-up, the median follow-up was 28 months, and we see how the median progression-free survival was not reached in the ibrutinib and venetoclax, whereas the median progression-free survival was 21 months for chlorambucil and obinutuzumab, and being assigned to treatment with ibrutinib plus venetoclax reduce your risk of experiencing progression or death by 78%, very significant. There were several pre-specified subgroups that were analyzed in this study, and the superiority for the dual, I call it dual targeted therapy, we know a BTKI and a BCL2I, was superior in all the pre-specified subgroup, including patient with older age, patient with bulky disease. It's important to notice patient with deletion 11q. It's important to notice that this group of expert investigators did not enroll patients with deletion 17p, and that is because you do not want patients with deletion 17p to have a chance to be randomized to a treatment that does not contain targeted therapy, such as chlorambucil and obinutuzumab. As I said, the rate of overall response rate was higher with patients treated with the dual targeted therapy, and same was for the percentage of patients that achieve undetectable measurable residual disease. The undetectable measurable residual disease was reached with the dual therapy was 55%, versus 39% with patients treated with chlorambucil and obinutuzumab. But what the panel on the left lower quadrant shows is that the dual inhibitor therapy was able to better maintain undetectable MRD with 85% of the patients that did not experience a change in their MRD versus 3/4 of the patients that were treated with chlorambucil and obinutuzumab. 70% of them nearly experienced progression in the MRD. So we see, deeper responses and more durable responses. Looking at toxicity, this is what was expected, and there were some toxicity typical of the BTK, such as atrial fibrillation and hypertension, that were not seen in the patient randomized to the chlorambucil and obinutuzumab. However, it's important to point that the rate of neutropenia was similar. The rate of infection was slightly higher for the patient with the dual inhibitor therapy, that, as we all know, is also a longer type of therapy because it continued for a total of 15 cycles, whereas the chlorambucil and obinutuzumab stopped at 6 cycles. So again, very important data from the toxicity are that even in a population of older patients with comorbidity, the dual targeted therapy, it can still be delivered safely. And just by pointing at the tumor lysis risk, I think everyone has gotten so well versed in handling venetoclax in this setting that we saw a little bit of a higher rate of tumor lysis syndrome risk in the patient treated with obinutuzumab, because the 3 cycles of lead-in with ibrutinib really reduce the risk of tumor lysis, and the stepwise approach when you introduce venetoclax makes delivering this treatment very safe, even in this population of older patients. We can move to the next slide. So we are going to stay on the same type of regimen. That is the 3 months lead-in of ibrutinib, followed by 3 cycles of lead-in of ibrutinib, followed by 12 cycle lead-in of venetoclax. This is a phase 2, again, for patients treated for a frontline therapy. And this was presented at ASCO by Dr. Ghia. The Captivate has 2 components. This one, that is the one with final time of treatment with definitive treatment, was the one that was presented. The patient population, so the studies have some similarities, but there are also some differences, because the patient population here is a patient population with age less than 70. And this is a patient population that has high risk feature. 50% of the patient had a high risk feature, and 17% of the patient in this study had a deletion 17p or a TP53 mutation, being the higher risk group. This is a difference from the population that was enrolled in the GLOW that excluded the deletion 17p. So the primary endpoint was based on achieving a complete response rate that will be superior to the one seen with chemoimmunotherapy. And they set the complete response rate that they wanted to beat to 37%. They look at it in 2 populations, one that was patient without the deletion 17p, and one was for the all treated population. The goal was achieved because the complete response rate and complete response rate with incomplete recovery was 56% for the patient without deletion 17p, and was 55% for if we look at the whole population. This is a treatment that gives a persistent response, long lasting. So progression-free survival was the same, was very good, with a 96 and 95% progression-free survival at 24 months of follow-up for both patients, the group without the deletion 17p and the group that include the deletion 17p. Overall survival was the same. and then at 96%. And then they, of course, wanted to look at how deep the responses were, because we know the depth of response correlates with the response duration. So they look at undetectable MRD, and the undetectable MRD in the peripheral blood and in the bone marrow was 77% for the whole group and 60% for the whole group. They look at other groups of patients. They found a higher level of undetectable MRD in patients without bulky disease. And they were able to find a better undetectable MRD in patients with mutated immunoglobulin heavy chain gene. However, the most marked one that is not shown in these slides was in the patient with the deletion 17p and TP53, where actually the rate of undetectable MRD in the bone marrow was 40% compared with 60% for the whole population. So this is again very positive results for the dual inhibition given safely for patients with a high-risk disease and a treatment that is time-limited. The next slide. So at ASCO, there was an update given by Dr. Sherman regarding the ELEVATE treatment-naive study. This was a 4-year update. The study is a frontline therapy for patients with the usual characteristics, age 65 or older or younger than 65 with comorbidity, and the patients were randomized to be treated with acalabrutinib and obinutuzumab, acalabrutinib as monotherapy, or the control arm of chlorambucil and obinutuzumab. What they showed at 4 years is that the progression-free survival for the acalabrutinib plus obino is 87%, acalabrutinib as monotherapy is 78%, and chlorambucil and obinutuzumab is inferior at 25%. Overall response rate are similar between those three treatment arms. However, complete response rate are higher when we look at the combination of acalabrutinib and obinutuzumab at 30.7% compared to 11.2% and 13% for the other two arms. Again, looking at event of clinical interest, the event of clinical interest that are included here show how the patient treated with the acalabrutinib plus obinutuzumab experienced some of the BTKI typical toxicities, such as atrial fibrillation. It was 4% atrial fibrillation in patients treated with acala plus obino, but only 0.6% of the cases were of grade 3. It was 6.1% for acala as monotherapy, with 1.1% for grade 3 or higher, and of course, very little seen in the obino plus chlorambucil. I want to point out hypertension, that is another cardiovascular toxicity seen with the first generation BTKI, was not really seen in this study with the same rate between the three arms. So this was a nice update. The study was not designed initially to show a difference between acala and obino respect to acala as monotherapy. And this is why, since this is an open question for CLL investigator, whether BTKI should be used with or without monoclonal antibody, this is why the updates of the ELEVATE-TN are always followed with interest. We can move to the next slide. Whereas for the ELEVATE treatment naive, that was an update, the ELEVATE relapse refractory trial was presented for the first time by John Bird at ASCO. This is a study that could be compared a little bit with the one that we saw at the beginning, that is the Alpine trial. It's similar in design. Patients with relapsed refractory disease were randomized to receive treatment with either acalabrutinib 100 milligram twice a day or the standard arm of ibrutinib 420 milligram daily. However, there are some difference in patient population, because for the Elevate RR, they specifically selected for patients with high risk feature, and the presence of a deletion 17p or deletion 11q was one of the requirements. This was also, so there is a very high number of patients with deletion 17p at 45%. This was also a non-inferiority study, therefore the primary endpoint was non-inferiority in terms of progression-free survival. This endpoint was met. There is also no difference in overall survival. That was a secondary endpoint. No difference in the rate of transformation to Richter syndrome, and no difference in terms of grade 3 infections. Again, we are comparing first generation versus next generation BTKI, so we will focus on cardiovascular toxicities. Those are shown in the left lower panel. The rate for atrial fibrillation was higher in patients treated with ibrutinib, with an overall rate of 16% versus 9% for the patient treated with acalabrutinib. Hypertension was more common. It was 22% of the patients treated with ibrutinib versus only 8% of the patients treated with acalabrutinib. It was also noted that, in particular with the patient treated in terms of the atrial fibrillation tend to have a later onset in the patient treated with acalabrutinib versus an earlier onset for the patient treated with ibrutinib. And hypertension, again, was not really seen with acalabrutinib to a significant level, but continued to increase for the patient treated with ibrutinib. Again, very good information we are getting from those large studies that look at comparing BTKI. Next slide.
Yeah, I think the next one is for Dr. Mattisar.
Hi, everyone. Good afternoon. So here, shown here in just a single slide is a summary of the data underlying the Kronos 3 report that Pierluigi read out at EHA, and was sort of a companion to our concurrent publication in Lancet Oncology. As a reminder, C3 was a randomized clinical trial for patients with relapsed indolent B-cell lymphomas across the spectrum, and was a randomization to either rituximab monotherapy plus placebo or rituximab plus copanlisib. This was intended for patients who were rituximab sensitive, meaning that they had gone at least 12 months since their last rituximab-containing treatment, or 6 months if they were deemed unfit or unwilling to receive chemotherapy. And randomization occurred in a 2-to-1 fashion. Patients received COPA according to its usual schedule of 3 doses out of every 4 until progression or intolerance, and they received loading with rituximab over the first 8 cycles, and then that stopped. What we learned from C3 was that you can safely and effectively combine copanlisib, which is an intravenous pan-PI3K inhibitor, with specific activity against the alpha and delta isoforms of PI3K. And we see that there was an improvement in overall response rate and complete response rate across the spectrum of indolent B-cell lymphomas, an improvement in overall progression-free survival, as well as improvements by subtype analysis for FL, SLL, and marginal zone, with a tendency or trend towards positivity for Waldenstrom's, although with relatively few patients with that histologic subtype, it did not achieve statistical significance. Safety-wise, we saw that the combination was sort of in line with what you'd expect from the component parts of the C3 regimen, rituximab and copanlisib. Copanlisib's chief toxicities being hypertension and hyperglycemia that occur around the time of infusion. So the takeaway from C3 was that you can safely and effectively combine copanlisib with rituximab. This is the first time we've been able to combine a PI3K with rituximab safely, and establishes this treatment as a potential new standard option for patients with relapsed indolent B-cell lymphomas. Next slide.
I think next one is for Dr. Ferrari.
Yes, this was another 4 years update, a very welcome 4 years update of the CLL14 study. The CL14 study from the German Cooperative Study Group is a first-line therapy for patients with CLL with the same characteristic we have seen for the majority of the first-line study that we have reviewed earlier, and that is age 65 or older or younger than 65 with comorbidity. The patients are randomized to receive either treatment with venetoclax and obinutuzumab or the standard of care of chlorambucil and obinutuzumab. This was an update that was provided by Dr. Al-Sawaf. What we see is that at the 4-year time, the progression-free survival rate is higher, significantly higher with the combination of venetoclax and obinutuzumab at 74%, compared with chlorambucil and obinutuzumab. This is frontline therapy, so it's not a surprise that there is really not a significance yet, clear significance yet in terms of the median overall survival. We will have to look at, further follow-up of this study. However, at 4 years, the venetoclax obinutuzumab was 85% versus 83% for the chlorambucil and obinutuzumab. What is very important is to look at what happens in terms of MRD. When you look at those colorful panels, anything that is green is undetectable, measurable residual disease, is considered MRD negativity. The rate of MRD negativity was much higher for the patient treated with the combination of obinutuzumab and venetoclax respect to chlorambucil and obinutuzumab. But what is particularly important is that the time to detection of MRD was also longer for the patient treated with the venetoclax and obinutuzumab. It was 21 months, whereas the time to detection, the median time to detection of MRD for the patient treated with chlorambucil and obinutuzumab was only 6 months. So in terms of progression-free survival, we already reviewed. There was also information regarding progression-free survival in patients with deletion 17p, and this was shorter compared to the one of the rest of the group. What is important is that in terms, as we said, we have detection of MRD that is shorter for chlorambucil and obinutuzumab, but we also have a higher rate of patients treated with chlorambucil and obinutuzumab that require treatment. 40% of the patients treated with this arm required retreatment versus only 19% of the one treated with the combination of venetoclax and obinutuzumab. When we look at the side effects, again, these strengthen what we have said before, and that is that the more intensive treatment of venetoclax and obinutuzumab was still well tolerated. It could be delivered to this older population, and there was no significant difference in terms of myelosuppression or in terms of complications. So this supports the concept that we are observing a paradigm shift and more intensive treatment. When they are based on targeted therapy, they can safely be given to older patients with the CLL, and this is very different from what we used to see with chemoimmunotherapy. Next slide.
Can we go to the cell therapy section now?
Next slide. I think is.
Yeah. So over to Dr. Shadman, who will walk us through some of the updates from the cell therapy space.
Hi. So moving to cell therapy, namely CAR-T therapy for lymphomas, and we have 2 abstracts focusing on follicular lymphoma. As we know, we already have one FDA-approved product, and that's Axi-cel, approved for follicular lymphoma after 2 lines of therapy. Just before we start going through the 2 abstracts, for follicular lymphoma, we need to think about unmet needs. number of molecular therapy approaches and targeted therapy approaches for follicular lymphoma are now available. The question is, where does CAR T therapy fit in that treatment landscape? Also, we do know that 20% of our follicular lymphoma patients will fall under the category of high-risk patients who have a poor response to our conventional treatments, and their overall survival is very different than our other standard risk follicular lymphoma patients. So the two CAR T studies that we're covering here, and we can move to the next slide, please, starts with the ZUMA-5 trial. And this study is already presented before, but this abstract focused on looking at the response to axi-cel in patients who had POD24 or not. So POD24 being progression of disease within 24 months of finishing chemotherapy or first line of therapy. We know that these patients are extremely high risk with reported and published data indicating a 5-year overall survival rate of 50%. And this number has been replicated by many investigators. So really a true unmet need. The current standard of care is for most is to try to achieve a complete remission and move to autologous transplant. The question is, can CAR T be utilized in that setting? And this interesting and important abstract tries to look at that question. So as a reminder, again, axi-cel is a CD19 targeted CAR T product. It has CD28 as a co-stimulatory molecule, which is important when we look at the toxicity profile of this product. So the inclusion criteria for this study, which included both follicular lymphoma and marginal zone lymphoma, by the way, included patients who had at least 2 prior lines of therapy, which had to include a CD20 targeted monoclonal antibody and an alkylating agent. And patients received basically CAR T therapy as it is a standard for axi-cel. They did receive lymphodepletion with fludarabine and cyclophosphamide, and that was followed by axi-cel infusion. So you see on the top right, the figure looking at on the left side, patients with POD24, 61 patients who had progression within 2 years of finishing induction chemotherapy. And in the right panel, you see patients without that. So those would be the standard risk patients, if you will. So the overall response rate between the two groups seems pretty similar at 92%, although patients with POD24 had a lower complete response rate at 74% versus 86%. If you look at the duration of response, progression-free survival, and overall survival, just looking at the curves, you do see that the curves are not necessarily overlapping. So patients with POD24, although the median DOR or PFS is not reached, the numbers seem to be smaller. For example, if you look at the PFS at 18 months with POD24, you do have 55% versus 84% for patients without POD24. So it is effective. It's definitely probably better than most of the standard treatments. Within patients who received the CAR T therapy, those who had POD24, at least just numerically, the numbers and the long-term remission seem to be inferior compared to the non-POD24s. But again, the real question is how these compare to our alternative therapies. And this seems to be a very promising and very important treatment options for patients with POD24. Now, with follicular lymphoma, any indolent or low-grade lymphoid malignancies, toxicity profile is extremely important. So if you remember from the ZUMA-5 study, the rate of grade 3 or more CRS was around 6%, with a rate of neurotoxicity that was grade 3 or 4, 15%. That's not a small number for histology where you have many treatment options and so many upcoming ones. So something to remember when we move to the next slide, which we can move to the next slide, would be another presentation, again focusing on follicular lymphoma, this time using Tisocel or Kymriah, which is another CD19 targeted CAR T. This one has a 4-1BB co-stimulatory molecule. We know from some preclinical data that the difference between CD28 and 4-1BB co-stimulatory CARs, you do see differences in terms of timing and severity of neurotoxicity and CRS. And again, it's not right to compare between the trials, but just looking at this study, this is LARA, which targets patients with follicular lymphoma using Tysa-cel. In this study, patients received lymphodepletion. Not necessarily everybody got fludarabine and cyclophosphamide. Some patients actually did receive bendamustine as lymphodepletion. The timing of response assessment was slightly different at 3 months versus 1 month with the prior study. But you do see that this product is very effective with the CR rate of 66%. I remind you that at Zuma 5, in Zuma 5 study, the overall CR rate was 76%. But again, we can't really compare between the trials. I would say the CR rate somewhere between 60 to 70% is what you get from CAR-T probably. And the responses were durable, although you do see with that PSF curve that, after a year, there may be drops, but, we've been taught not to look at the tail of the curves very, tail of the curves for Kaplan-Meier estimate. So I think that the Tysa-cel in follicular lymphoma seems to be effective with durable responses. Now, again, going back to that principle of the safety profile in when you have a very busy treatment landscape and many other options. If you focus on the adverse event table of a special interest with the box that focuses on cytokine release syndrome and neurological toxicities and focus on grade 3 or more, you have no CRS of grade 3 or 4, and you only have 1% neurotoxicity, which is grade 3 or 4. And again, remember 15% from axi-cel. So I think this is extremely important. Focusing on the POD24 is one thing, and then eventually we need to have more mature data from both CARs to decide which one is more effective, because that's a setting where you really look for effectiveness and achieving remissions in patients who are highly refractory. But for most other patients, I would say it's very important to focus on the safety profile. And here we do see a very promising signal. I remind everybody that the study is ongoing for liso-cel and follicular lymphoma, and a number of other 4-1BB co-stimulatory CARs, including CD20 CARs, are also ongoing. I think we can move to the next slide.
Right, so over to Dr. Matissar on the CD20 bispecifics.
So here we have crammed like an awful lot of scholarship into one slide. But clearly there's a lot of work being done in the development of bispecific antibodies in the treatment of B-cell lymphomas, both indolent and aggressive. I'll start us on the right-hand side of this slide with your permission. We'll start with the GLOFIT data on the upper right hand. This is the data from the GLOFIT step-up dosing. Again, this is across the B-cell lymphoma spectrum in the relapse refractory setting, with the data here divided into the aggressive and indolent histologic subtypes. On the left is shown the aggressive patients, and you see that the overall all comers with 28 treated patients treated to date, an overall response rate of approximately 2/3, the majority of which being CRs. And particularly in the aggressive subtype, you'll see that as you get the dose up to what they think is their likely MTD, which is the 2.5, 10, 30 cohort, that you really see an extraordinarily favorable response rate. 3/4 of patients responding, again, the majority of these as complete responses. In the indolent side of the curve here, we know that indolent B-cell lymphomas are sensitive to many of these bispecific antibodies. But again, you see that there's a dose response. And with the GLOFIT data here, overall 70%, but really as you start getting the dose up, once you have even the 16 milligram cap cohort, you see that the vast majority of patients are responding. And again, very high CR rates. On the bottom right is the data from EPCOR, their monotherapy. This is a drug that's given subcutaneously in contradistinction to GLOFIT, which is intravenous. Be that as it may, the overall response data is shown here. And you see that, again, across the spectrum of lymphoma, this is a highly active compound, particularly once you get up to their higher doses, with peak dosing from the step up at 48 to 60 milligrams, nearly uniform response rate in the DLBCL treated patients, although a small n, an overall response rate of 91%, half of which were CRs. In FL, the majority of patients responded as well. And in MCL, which is a histology with which we don't have a lot of data for any of the bispecifics yet, we see that in a tiny number of treated patients that the drug is active in that disease setting as well, not surprisingly. What isn't shown here is the toxicity data, and both Glofit and Epcor do have toxicity challenges with rates of cytokine release syndrome, grade 2 or greater, and grade 2 for CRS translates to can't be given in the oncologist's outpatient clinic in Topeka, Kansas safely and effectively. These both have rates of grade 2 CRS that still need to be brought down further to be able to make them a fully outpatient community-friendly regimen. Mosunetuzumab is a little further along in its development, both in terms of number of treated patients as well as mitigation strategies to try to limit CRS down to ranges where it could be a fully outpatient regimen. And the data supporting its ongoing development in the relapse refractory setting, both in follicular and aggressive histologies, have led to sort of its second generation of trials, including the two shown on the left here. On the top, we see mosun monotherapy not in relapse refractory disease, as has been studied to date, but first experience using it as monotherapy in newly diagnosed diffuse large B-cell lymphoma for patients who were felt by the treating physician to be unfit to receive standard of care anthracycline-based chemoimmunotherapy. And given all by its lonesome self, we see that mosun does have pretty good activity in this very high-risk patient population with an overall response rate of 60%, 40% CR rate. And these numbers hold up both in terms of their middle and higher dosing strategies. The company is obviously very interested in leveraging mosun either as monotherapy or partnered therapy in the treatment of newly diagnosed large cell lymphoma, and that work is ongoing. The companion study to that for discussion today is the mosun-pola combination therapy, here being studied in relapsed or refractory disease. And you see that this combination does achieve, pretty good overall response rates and complete response rates of almost 70% and over 50%, very active in aggressive histologies, a relatively small number of post-CAR T patients, but that's a patient population that is both very hard to study and very hard to manage. And patients were able to be put on to study with that clinical scenario, and they responded to bispecific antibodies combined with the CD79B, MMA delivering antibody drug conjugate. Only 3 patients with FL treated so far. All 3 of them responded. That's good news. But what's more important, and this sort of is analogous to the talk that you heard from my colleague talking about the toxicity profile of Tesogen versus axi-cel in low-grade follicular lymphoma, is trying to push the needle on CRS when we think about the bispecifics as they enter the marketplace. And seeing in this patient population, the CRS rate of all grade 1, and even there less than 10%, all happening predictably during the step-up dosing during cycle 1. This is the best that we've seen in terms of our ability to give bispecifics safely and really trying to avoid grade 2 plus CRS. Very encouraging data in my perspective.
Thank you, Dr. Nassar. Move on. Next, we move on to some of the novel investigational drugs across the different malignancies that were discussed at the 3 conferences. So over to Dr. Shadman and Dr. Faraholi. Dr.
Yes.
Shadman.
So we'll quickly review a few novel therapeutic agents here in drugs. So starting with an antibody drug conjugate, we have now number of antibody drug conjugates for lymphoma treatment, basically targeting CD79B and CD19. So this is another example of an ADC that targets CD37, an antigen that has been studied for treatment of lymphoid malignancies now for a long time. So this study uses a DM1 chemo attached to the CD37 antibody. And this study basically looked at the safety and efficacy of this agent in a number of B-cell non-Hodgkin lymphomas. So basically, after the part 1, which included some safety and then expansion run-ins, the part 2 really includes 2 different schedules, every 3 weeks or weekly treatments, and they targeted on diffuse large B-cell lymphoma for this presentation. Responses for 80 patients that they treated, and the CR rate seems to be around 50%, with a slightly higher CR rate in patients in cohort A. and those are patients who received every 3-week scheduled treatment. And of course, as expected in patients who did not have bulky disease, the overall response rate and CR rate was higher. Duration of responses, again, these studies in general, the next few that I will be presenting is not very long. They do not have a long-term follow-up, but the responses seem to be durable without the evidence of early drops, which is important. And I think probably one of the more important features of looking at these studies at these stages is looking at the safety profile. We know that with lymphomas, and specifically with large cell lymphoma, it would be less likely for a monotherapy to be the answer for large cell lymphoma. So eventually these drugs will look into combinations and being added to the chemotherapy backbones, or more recently some immunotherapeutic backbones or novel drugs. So it's important to look at the safety profile. If there's a red flag, that may eliminate some of the potential partners for this drug. And we really don't see any safety signal here other than what's expected for a drug that is intended to treat lymphoid malignancies. We have cytopenias, and really the small number of 8% of patients who ended up stopping treatment due to toxicity. I think that's promising. I think this would be a drug to continue to monitor in upcoming meetings and maybe publications. I think efficacy is reasonable. More importantly, as I mentioned, safety, I think, gives the drug the opportunity of being part of some other combinations for lymphomas. We can move to the next slide. The next drug is Lysaftuclax. It's a BCL2 inhibitor. We were familiar with venetoclax. We just heard about the updates from the frontline therapy for CLL in combination with obinutuzumab. So really, this is another BCL2 inhibitor, and we heard about this presentation at ASCO. So the unmet needs, probably, I would say, with BCL2 inhibitor, of course, there's still room for improvement in efficacy and having deep remissions and achieving high MRD negativity. So eventually, maybe we see that with novel BCL2 inhibitors. Also, one of the practical challenges, as we all know, is the weekly ramp up and the long basically interval or timing of getting the patient to the therapeutic dose. So starting from the design of the study, they included 2 cohorts, the non-CLL cohort in which patients did not have a high risk for TLS, and then they had cohort B, which was our CLL patients or patients with other histologies who had high risk for TLS. And the group that was a non-CLL and low risk for TLS did not have a ramp up for the BCL2 inhibitor. The CLL group or patients with high risk for TLS followed a daily ramp up. So again, if this continues to be the schedule for this drug, and if the drug also shows efficacy that's acceptable, I think that would be an important maybe differentiating factor at this point to be able to have a different type of ramp up a schedule. But again, focusing on what's important in a study at this phase, the safety profile, as I said, I don't see any significant red flags other than what is usually expected with a drug that is used for heme malignancies with cytopenias, and here we have around 20% diarrhea. Then the response rates, if you look at the table in the lower left, this is for non-CLL SLLs. I would say time on treatment is not very long, and the quality of responses are not great yet. I mean, most of them are in terms of or in form of stable disease. But again, this is something that we need to follow longer to learn about the efficacy. On the right, though, you do have CLL patients, and the swimmer plot that shows that you have an overall response rate of 80%, again, mostly in the form of PR. Some of them achieved pretty early. If you look at the study table 1, which is not included in this slide, remember, these are not necessarily super high-risk CLL patients, so nobody has previously been treated with a BCL2 inhibitor, and only around 25% or 26% had a prior BTKI exposure, and that could have been failure or intolerance, so it's not specified. So, but again, understanding the limitations of having a clinical trial in the CLL space these days, I think we're seeing reasonable efficacy in CLL at this point, and we do need more follow-up and more information for non-CLL histology. As I said, the unmet needs are improving the efficacy of venetoclax and maybe making it more user-friendly, and the daily ramp-up could be a differentiating factor, and we do need to wait for the continued efficacy assessment, and also if there is more safety, if there's any safety signal in longer follow-up, that would be important, because BCL2 inhibitors are commonly combined with other agents for treatment of CLL and other histologies. Next slide, please. Then we have another antibody. It's a monoclonal antibody, cemtuzumab, which is a drug that a fully humanized antibody targeting the ROR1. A few years ago, we saw single agent data for CLL and other malignancies with modest activity. So there is preclinical data indicating potential synergistic effect when you combine this drug with novel agents, including ibrutinib. So this study reports on results of combination of cemtuzumab and ibrutinib for CLL and mantle cell lymphoma at different parts, including this study is not reporting on that part, but there is a part that is a randomized study comparing ibrutinib monotherapy with ibrutinib in combination with cemtuzumab for CLL. And I think that would be potentially important, as we know, at least for ibrutinib, we don't have any evidence of combining with any monoclonal antibody would be beneficial based on the data we have, at least for CLL. So that part is not presented. I think what we see here is if you look at different PFS, basically curves for both CLL and mantle cell lymphoma, these look pretty similar to what you'd expect from ibrutinib, to be honest with you. So it's great that there's no safety signal or concerns with combining the antibody to the ibrutinib, but really, I think it would be very important to look at the randomized trial to see if the antibody really adds anything to ibrutinib. As I said, both for mantle cell lymphoma and CLL, if you look at the top the curves, and again, it doesn't look very different than what you expect with monotherapy with ibrutinib. But I think it's lack of any safety signals and then waiting for the randomized data, which seems to be completed per this presentation, but we'll hopefully get the presentation at some point for that piece. If we can move to the next slide, and I think Dr. Seriali will.
Yes, I'll be presenting this slide. This is the Bruin study looking at pirtobrutinib that many of us are more familiar under the name of LOXO 305 in patients with previously treated CLL, SLL, mantle cell lymphoma, Waldenstrom macroglobulinemia, other non-Hodgkin lymphoma, and Richter transformation. What is pirtobrutinib? Pirtobrutinib is a non-covalent reversible BTK inhibitor. So the one that we reviewed earlier were all covalent and irreversible BTK inhibitor. The advantage of being a non-covalent and irreversible inhibitor are based on a more specific targeting for BTK, a better pharmacodynamic profile, because it does not really dependent on the turnout of BTK itself, and therefore preliminary data have shown that this agent is very selective for BTK, does not target other kinases, and has similar efficacy in patients with wild-type BTK and patients with mutated BTK with the CYS381 mutation. So it's really a very useful agent to test in the setting of BTK progression while on treatment with BTK. So when we focus on the CLL population, this is a very good efficacy for patients with relapsed refractory disease. As with other BTK, the majority of the responses are overall response. and consist in partial response with a small proportion of patients achieving complete responses at this time. When we look at patients with mantle cell lymphoma, again, very good overall response rate, 52%, and the overall response rate is the same in patients that had received prior BTK and patients that had not received prior BTK. However, personally, of the data that were presented at EHA, and the most exciting part is the one in Richter transformation, because truly seeing a 67% response rate as a monotherapy in patients with Richter transformation with about half of the responses to be durable is extremely exciting, because I know for sure that we will see a lot of data with pirtobrutinib, and we will see pirtobrutinib combined with many, many other agents, because it does represent a very good partner for combination. They did not see any cardiovascular toxicity or any atrial fibrillation, supporting the fact that this agent is really targeted. So I think this is the first look at this agent, but there is a lot more to come, especially in combination. Next slide.
Thank you. The last one is Dr. Matissar discussing updates from Hodgkin.
Great. So Dr. Ferrajoli gets Loxo and I get tislelizumab. That's not fair, but it's okay. So you might be asking yourselves, do we really need another PD-1 inhibitor? And the answer is, I'm not sure either. Be that as it may, this is BeiGene's novel entry into the crowded class. It has some theoretical benefits. It's supposed to be engineered in such a way that it doesn't bind macrophages, Fc gamma receptors, to try to avoid macrophage-induced destruction of effector T cells. That's the story that they tell. Here's the data in multiple relapsed classical Hodgkin lymphoma that was naive to checkpoint inhibitors previously, and it looks active as you would expect from a drug with its mechanism of action. Very good response rate and very good PFS in a small but selected patient population. It's impossible for me to derive from the data from Tisla whether this is a best-in-class or better drug, but what it does is it opens opportunities for BeiGene to develop combination therapeutic strategies. They're developing a host of other checkpoint inhibitors. They have a TIM3, an OX40, a TIGIT, in addition to zanubrutinib and other medicines. So it gives them a platform on which to develop multi-agent therapeutic studies without requiring partner companies in the future.
Thank you. This was a very interesting and exciting presentation. We've covered quite a bit, and we're left with the last 4 minutes. I think in the interest of time, maybe we can scan through some of the questions that came in. So maybe next slide, Maura. Some of the questions, and I'm just going to read out a few that were not answered. First question was about the Alpine trial. Does that make does that indicate that zanubrutinib is the best-in-class BTK inhibitor?
Well, I think it's too early, because this was the first ad interim plan analysis. Like with every study, personally, I would like to see overall survival data to show the superiority of the agent. And once we have overall survival data and we have better tolerability, then we can call the drug the best. I think it does give us a hint, though, that next generation BTKI have similar efficacy and better tolerability.
Thank you. And the next one on cell therapy, there were 2 questions on the use of cell therapy in earlier lines. And this is not just on the data that you discussed, but also some of the other data that came out on second-line therapy. So for something like an FL second line, would cell therapy be an option? Would you consider it to be the first line or first option, or would you still go back to some of the combinations that exist?
Well, I mean, is it possible? Yes. Are we there? I don't think so. I mean, you just heard about bispecific antibodies. There are many other classes that are available. So again, safety profile is extremely important for low-grade lymphomas in order to bring it to earlier lines of therapy. But we'll see if the safety profile that we saw with the 4-1BB CAR holds with other products or maybe novel ones. It is possible to either use it as monotherapy or as combination with some of the other novel agents in form of a consolidation or maintenance. So I think it's possible, but there's a lot of work to do in the low-grade lymphoma field. In high-grade lymphoma, and I saw a question, there are 2 press releases in June. So let's wait for the data. But just very briefly, since the question was asked, there are 3 studies comparing CAR-T with standard of care in patients with primary refractory large cell lymphoma, which is no response to first-line therapy or relapse within 12 months. We just heard from the sponsors that both were positive for their primary endpoint, which was event-free survival, and some of the secondary endpoints, which did not include overall survival. So, I mean, we'll need to look at the data, but if the studies are potentially CAR-T for primary refractory patients could come to the second-line therapy there. In the interest of time, I think I'll stop here.
Dr. Madasar, any comment on that? On second line?
Another hour about CAR-T and large cell, but I agree with my colleague. We try not to practice medicine based on press releases. These studies were both written to be positive with EFS endpoints. We know that the EFS is better for CAR-T than it is for platinum to an auto. That surprises nobody. The devil will be in the details, and we're all looking forward to ASH.
Andrew, you want to take the next one?
Yeah, one question here on Kronos 3. How do we think about the PI3K class, appreciating this some PFS data, especially thinking about it with AEs? That's always been kind of the story with the PI3K class, and I'm curious if you can contextualize that relative to R-squared.
I'll challenge the question that's premise. I think that there is no such thing as a class of PI3Ks. I think these drugs are all very different. If you want to lump Idel and Duvela, I welcome you to do so. They seem pretty close if you're not treating T-cell lymphoma. But COPA is very different than both of them. And honestly, Umbra is probably pretty different than both of them. The toxicity profiles of Umbra and COPA are quite different from each other, and both quite different from Idel and Duvela. COPA's toxicity profile is excellent. It does not cause transaminitis, hepatitis, pneumonitis, enteritis, the terrible stuff that we see with daily oral PI3Ks. Its main toxicity is that it's a pain in the butt to give. It's weekly IV 3 weeks out of 4. That's hard for a lot of patients. Umbra's toxicity profile is not quite as favorable as COPA, but it's better than Idel and Duvela, and it's an oral therapy. Whether that's where we end or whether we're going to be looking at novel drugs that are being developed, that are being given in a loading strategy and then being taken to a maintenance approach, that you may get the best of both worlds. There's a lot of work ongoing, but I would caution you not to think about these drugs in a class, which is in distinction from how we think about most of the stuff that we do.
Thank you. Andrew, do you want to take your next question on BTK as well?
Sure. I was curious a little bit. There was the BTK inhibitor from ASH a couple of years ago. I think it was 2019, the Arcule one that's now being developed by Merck. I feel like we haven't heard much about that lately, but curious, where that fits in the next wave of BTK inhibitors.
Yes, it's supposed to have similar characteristic to Loxo in being a, different type of BTK inhibitor with the non-covalent and reversible binding. However, at least based on the limited data that I've seen so far, it seems to have a little more toxicity than the competitor, but I know there are studies ongoing throughout the low-grade lymphoma. So I think it's another one that we will see more data at ASH coming up.
Thank you. And the last question for Dr. Madasar, which I think I probably have asked you every conference, the differences between the bispecifics. Did these set of conferences change anything on your opinion? I know we spoke about the Pola combo, but
I think in my take on it, and admittedly I'm biased because I'm involved with the development of Mosun and Glofit, so I'm inherently biased towards those compounds, so take my opinion with a grain of salt. But I think that Mosun has distinguished itself as the best tolerated of the 4 chief competitor compounds. Mosun, Glofit, Epcor, and Regeneron. Glofit's activity seems excellent. It's a little bit higher CRS than Mosun. Epcor seems as good as Glofit activity-wise, but the CRS is even a little bit worse. Regeneron is a little bit behind everybody else right now. So the toxicity profile matters. In settings where you really are trying to minimize toxicity, Mosun looks the best. In settings where you're really trying to maximize your activity for aggressive disease, maybe Glofit or maybe Epcor.
Thank you. Thank you so much. This was a absolutely enlightening discussion. We've covered a lot of ground. So thank you so much for your time. Thank you for your insights. And we'll hope to have you again on this forum to discuss some of the other updates that come in the next upcoming conferences, the ASH or any other ones. So thank you. Have a good day. Thanks once again.
Thank you, everyone.
Thank you.
Bye-bye.
Thank you, everybody.